Hello everyone, I welcome you all for today's session. I am Dr. Priyanka here, and today I am here to teach you a very important topic from systemic pathology, that is a topic from cardiovascular system, ischemic heart disease or coronary artery disease. This is a topic where most of the students find difficulty, so I will teach you this topic with simplicity. Before starting the ischemic heart disease or coronary artery disease, you must understand the blood supply of the heart. Yes, so just a second, let me move ahead. You can see here, this is a diagram, a sketch diagram of the heart. You can see heart has four chambers. This is the left side of the heart having left auricle, left ventricle. This is the right side of the heart. You can see when left ventricle is doing systole, when left ventricle is contracting, so blood is coming into the aorta and distributing pure blood to all the body organs. So this is how heart is giving pure blood to all body organs. But for doing systole, the left ventricle, the wall of the left ventricle require energy. So the wall of the left ventricle for doing systole, for contraction, the cells of the walls of the left ventricle, cardiac myocytes, they require ATP. So they also need blood supply for that. So who is giving blood to the heart? The heart receives blood from coronary artery. Can you see a purple color artery in this diagram? So coronary artery is a branch of aorta. You can see from aorta it is arising. So the coronary artery is arising from the aorta. This bigger coronary is known as conductance coronary. From this coronary, small coronaries are arising and going to the wall of the left ventricle from outer to inner side. You have to understand, from outer to inner side, you can see. These are known as resistance vessel. And this is how the left ventricle is receiving blood. Have you got it? Now there are three coronaries. What are the three coronaries? Actually, there are two coronaries. The right coronary artery RCA and left coronary artery LCA. RCA do not have any further branch, but left coronary artery LCA have two branches further. It is left anterior descending artery LAD and left circumflex LCX. So total three branches are there: RCA, LAD and LCX. So LAD and LCX are the branches of LCA, that is left anterior descending and left circumflex, and RCA is right coronary artery. So total we are having three coronaries. Now how these three coronaries give blood supply to the heart? You can see that is the how right coronary and left coronary, they are arising from the arch of aorta. You can see. Okay, now let me draw a diagram. This is the three type of coronary: right coronary artery known as RCA, left coronary artery having two branches, left anterior descending LAD and left circumflex LCX. So total three coronaries are there. Now how they are supplying the various parts of the heart, that you have to understand, right? Let me draw a diagram of the heart. Okay, can you see the four chambers? If I cut the heart from here, how does it look like? Okay, so this is you can see the slice of the heart. If I'm cutting the heart and looking from above, you can see the two lumens. So this is a lumen of left ventricle. This is a lumen of right ventricle. Now I'm more concerned with left ventricle because most of the MI attacks, that is infarction, occurs in the left ventricle. Now there are three coronaries now. So left ventricle, see here, left ventricle anterior wall of the left end. This is anterior, this is posterior. For left ventricle, this is lateral. For right ventricle, this is lateral, and this is medial of both ventricles. The midline is the medial, right? Left ventricle anterior wall is supplied by LAD, that is left anterior descending. Do you have any doubt in it? No, you don't have any doubt, right? Left ventricle lateral wall is supplied by RCA, is supplied by LCX, and left ventricular posterior wall is supplied by RCA. RCA is supplied by RCA. What about the medial wall? You have said about the anterior wall, you have said about the lateral wall, you have said about the posterior wall. Anterior, lateral and posterior is done. Now what about the medial wall? Medial wall is interventricular septum. This interventricular septum is supplied by these both arteries. That is anterior 2/3 is supplied by LAD, you can see, and posterior 1/3 is supplied by RCA. So that is the supply of medial wall. Now you can say the supply of all four walls. Anterior wall by LAD, lateral wall by LCX, posterior wall by RCA, and medial interventricular septum anterior 2/3 by LAD and posterior 1/3 by RCA. So same beautiful diagram is drawn here also. Now you will get it. What is information given in this diagram? You can see the two cavities here, the two lumens, the two cavities in the ventricle. This is right ventricle, this is left ventricle. Now left ventricle, can you see the anterior wall is supplied by LED. You can see the lateral wall is supplied by LCX, and you can see the posterior wall is supplied by RCA. What about medial wall? This one is the medial wall, you can see. So anterior 2/3 is supplied by LED and posterior 1/3 is supplied by RCA. Give me a thumbs up. Now, if you got this point, you can understand MI or ischemic heart disease very well. Now, if there is an obstruction, you tell me, if there is an obstruction in LED, which wall will have infarct? The anterior wall will not get blood, and there will be infarct in the anterior wall. If LCA is obstructed, there is an infarct in the lateral wall. If RCA is obstructed, there is an infarct in posterior wall, right? So infarct will be on which wall? What will be the location of infarct in MI? That depends on which coronary artery is obstructed. So if coronary is obstructed, that particular wall, the cardiac myocytes of that particular wall will not get blood. So they will die because of necrosis, coagulative necrosis, and it will lead to infarct. So that is the pathophysiology behind it. So I have told you there are three arteries. So LED, first I told you LED supplies the anterior wall and also anterior 2/3 of the interventricular septum. You can see the purple color here. It is LED. So it is supplying anterior wall and anterior 2/3 of the septum. So it supplies anterior wall, anterior 2/3 of the interventricular septum and apex, right? It is most commonly obstructed, right? The second is LCX. It supplies the lateral wall. You can see this one, the blue one, LCX. It supplies only lateral wall. It is the least common to get obstructed. And last is RCA. RCA supplies the posterior wall. You can see it is supplying the posterior wall and posterior 2/3 of the interventricular septum. Posterior 1/3 of the interventricular septum. And this RCA supplies whole right ventricle also, right? So this is the sequence of their obstruction. Most commonly LED obstructed. Second most common RCA obstructed, and least common LCX obstructed. Have you got it? So this is the sequence. So you can say left, right, left. Left mate is LED, right mate is RCA only, one only, and the second left is LCX. So this is the sequence. Please learn it. Anyhow, you learn it, but please learn it. You have to learn the sequence. So this is the sequence of obstruction. What is the cause of obstruction? Most common cause of obstruction is atherosclerosis in any of these. But other causes are also there, but most common cause is atherosclerosis. Have you got it? So atherosclerosis causing obstruction and leading to the infarct of that particular wall, that is ischemic heart disease. Ischemia is leading to infarction, right? Now, I'm talking about ischemic heart disease. It is due to ischemia. If any part of the body is not getting adequate blood, that part will have ischemia. Because of ischemia, there will be coagulative necrosis in that part. So that is happening with heart also. So in heart, if coronary is obstructed, one of the three coronary is obstructed, that will lead to ischemia in the heart. So that will lead to coagulative necrosis in the heart. That is known as ischemic heart disease. There are four types of ischemic heart disease, also known as coronary artery disease, because ischemia is occurring because of the obstruction of coronary artery, one of the three coronary artery. So either you say ischemic heart disease or you say coronary artery disease, one and the same thing, because coronary artery obstruction is leading to ischemia. That is ischemic heart disease and coronary artery disease. There are four diseases which are present in this spectrum. One is angina pectoralis, one is MI, one is chronic ischemic heart disease, one is sudden cardiac death. All four together constitute coronary artery disease. It is like a syndrome, right? So out of these four, today I will teach you two. The most important is angina and MI. These two are most important. So let me start with angina, one of the IHD. So in IHD, there are four things. I will teach you two, angina and MI. Let's start with angina pectoralis. Can anyone tell me what is angina pectoralis? What is angina? How you differentiate angina from MI? The two types, the two spectrum of IHD. How you will differentiate the two? Okay, let me start with angina. Simply, angina is chest pain. You know, patients simply have chest pain. Chest pain. It comes in attacks. It is not constant chest pain. It comes in attacks. It comes, it goes. It comes, it goes. That is attacks. Like asthma, it comes in attacks. Anything which comes in attacks is known as paroxysmal. So there is paroxysmal pain in the chest to any patient with angina. So patient have paroxysmal recurrent attacks of chest discomfort. Don't say chest pain. Actually, sometimes not always it is pain. It may be discomfort also, right? It is substernal, just below the sternum, or precordial, just at the level of the heart. And it is transient. It is a transient MI. It is not permanent MI. It is transient, right? So that is the definition of angina. So in angina pectoralis, patient have chest discomfort. That is the definition of angina, which comes in attacks. So that's why it is paroxysmal. It is not constitutional. It is not continuous, and it is transient. It is transient MI, right? So that is the thing. Have you got it? Now, to understand angina, you should understand demand and supply. What do you mean by demand and what do you mean by supply? What do you mean by demand and what do you mean by supply? I have told you this is left ventricle. Everyone look, this is left ventricle. When left ventricle is contracting, blood is coming in aorta, right? And blood is giving, aorta is giving pure blood to all the body organs. So this is the supply of the heart. Heart is supplying blood via aorta, pure blood to all the body organs and fulfilling the requirement of all body organs. But for doing so, heart also need blood. Heart also require energy. So heart is receiving energy from coronaries. This is the demand of the heart. Heart is saying, if you give me blood via coronaries, that is my demand. That is my demand. If you give me blood via coronary, I will give you blood via aorta. So that is my supply. So demand and supply should be proportionate. So if you want more supply, my demand will be more. So it is the same way. Just suppose I am having an employee. I am paying a salary to the employee. So whatever salary I am paying, to that proportion I can take the work, right? I cannot pay less and ask for more, or I cannot pay more and ask for less, right? That the both things will not work. So that is a balance between demand and supply is always there. So whatever you are, the heart is supplying via aorta. In the same proportion, heart is demanding via coronary. So you are giving blood to the heart via coronary. On the contrary, heart is giving pure blood. Heart is doing the contraction and projecting the blood, ejecting the blood into the aorta. So that is demand and supply. That is now imagine a situation if any of the coronary is obstructed. So these coronaries are obstructed. Imagine these coronaries are obstructed. So you are giving less blood to the heart. So you are giving less blood to the heart. Heart will also give less blood to you. So the blood coming in the aorta will reduce. So blood coming in the aorta will, if you are giving less blood to the heart, the blood coming to the aorta. So there is an imbalance between demand and supply. Have you got it? If any imbalance, now you want the same blood. You want the same blood in the aorta by giving less blood to the heart. Is it possible? If you give less blood to the heart, what will happen? Actually, what is happening? See, these are the cardiac myocytes which are receiving blood here. So if you supply less blood to them, they will undergo ischemia. It is not necrosis. They undergo ischemia. So ischemia will lead to the pain. As soon as if blood supply is restored, the blood supply is restored. As soon as the blood supply is restored, the pain is went. So that's why it is in attacks. When blood supply is obstructed, it is causing pain. When blood supply is restored, there is no pain. So that's why it is an attack. Now there are three types of angina. You have to understand the mechanism of all three, the pathophysiology of all three types of angina. You got the definition of angina. Now there are three types of angina: stable or classical angina, unstable or crescendo angina, and transmental or variant angina. Learn the two names. Stable also known as classical, unstable also known as crescendo, and transmental also known as variant. So these are the three types of angina you can see, right? Now what is the difference between them? Let me start with stable angina, the classical one, stable one. It is the most common type of angina. Out of the three, the most common is the stable angina or classical angina. It is the most common. Actually, what is happening here? See, this is happening. Can you see what is the problem? See, in the coronary there is atherosclerosis. So there is less blood in the coronary. So all these coronaries are receiving less blood. All these coronaries are receiving less blood. So left ventricle is receiving less blood. So left ventricle will contract less because you are giving less blood to it. So less blood will come in the aorta. Less blood is coming. But that blood is sufficient for basal metabolism. For basal metabolism, that much blood is sufficient. So if I am sitting, not doing anything, that much blood is sufficient for living life, right? But if I am doing any exercise, if I am doing anything which increases my body activity, any exercise, I am doing running, jogging, anything. So my muscles need more blood. So I am asking for more blood from the aorta. But heart will say, no, I cannot give more blood because you are giving me less blood via coronary. Coronary is obstructed. So you are giving me less blood, I will give you less blood. I cannot increase my blood supply. So at that time, the person will have chest pain. So person have chest pain at the time of exercise. at the time of exaggeration. As soon as after exercise, the person will rest, again, pain is gone. So that is the pathophysiology of classical angina. You got it? So there is reduction in the coronary. Reduction in the coronary perfusion at a critical level due to coronary atherosclerosis. Coronary got atherosclerosis, so there is reduction in perfusion, right? But up to critical level, patient can live. So this patient will have pain during exertion, and there is no pain. Pain is relieved at rest. So patient have pain during exertion. There is no pain at rest. Pain lasts only for 2 to 5 minutes. If I start running, I will have pain. If I sit down, the pain is gone. So that is the thing. It is actually not pain. It is chest discomfort. If you ask what is happening, patient will have the hand on the chest. You will ask the patient, what is happening? Do you have pain? No, I don't have pain. I am having some heaviness in the chest. So the word so said by the patient is heaviness. I'm having pressure in the chest. I'm feeling a squeezing feeling in the chest. So it is discomfort. It is not actual pain, right? And pain is crescendo, decrescendo in nature. Pain increases, decreases, increases, decreases. It is not constant increases. That is the first type of angina. The second type of angina is unstable angina. What is the second type of angina? The second type of angina is unstable angina. What is happening here? See what is happening here. Instead of atherosclerosis, there is thrombosis. It is fixed. There is thrombosis. There is thrombosis. So, of course, again, there is less blood in the coronary. There is less blood, and patient will have pain at rest also. Not only during exertion, patient will have rest during pain during rest also. In the stable angina, pain was lasting for 2 to 5 minutes. Here, pain is lasting for more than 10 minutes. In stable angina, pain was crescendo and decrescendo, both. Here, it is only crescendo, increasing, increasing, increasing pain. And in stable angina, it was not pain, it was discomfort. Here, it is actual pain. Have you got it? So, have you got the differences between stable, that is classical, and unstable angina? Have you got it? Yes or no? In stable angina, the patient have chest discomfort. Here, the patient have chest pain. Here pain was during exertion, no pain at rest. Here pain is at rest also. Here pain lasts for 2 to 5 minutes. Here pain lasts for more than 10 minutes. Here pain was crescendo, decrescendo, both. Crescendo, decrescendo, crescendo. Here pain is only crescendo. So see the differences between the two, right? And the cause of both is different. In stable angina, pain is due to atherosclerosis in the coronary. In unstable angina, pain is due to thrombosis in the coronary. Please make a crystal clear concept. Coming on Prinzmental or variant angina. See what is the problem here. You yourself see what is the problem. Here coronary undergoes spasm. Can you see? This is the coronary. It undergoes spasm. That is vasospasm. So coronary is having vasospasm. So there is less blood supply to the coronaries. So patient will have pain. Pain will be at rest. It is focal. So till the time patient have the spasm, patient will have pain. Once the spasm is relieved, vasodilatation occurs. So pain is relieved. So that is the 3 types of angina I taught you. In the 3 type of angina, treatment is completely different, right? Treatment is completely different. So we are done. I guess we are done with angina pectoralis, one of the spectrum of coronary artery disease or ischemic heart disease. So we are done with angina, the 3 types of angina: stable, classical or typical. The second is unstable, also known as crescendo. The third is Prinzmental or variant. So you should know the patho. What is angina? It is chest pain. It is chest pain. But the reason for the chest pain is different. And it is paroxysmal. It is transient. It is not permanent. Right? Coming on MI. The second most important topic here to be understood is MI. Give me a minute. Okay. Okay. So give me a minute. So I'm coming on MI. The second important topic here to be understood is MI, myocardial infarction. It is a 5-star important topic for your exams. For university exams as well as for all competitive exams, many MCQs come from this topic. You should know MI under all these headings. You should know definition, etiopathogenesis, types of infarct, location of infarct. The most important is morphology, gross and microscopy of the infarct. You should know the clinical features also. You should know the diagnosis. You should know complications, and you should know the salvage therapy. Let me start MI. What is an MI? Myocardial infarction. It is the infarction of myocardium of heart due to decreased blood supply in the coronary, right? Here also there is atherosclerosis. You see, in the coronary there is atherosclerosis. So less blood is coming via coronary. So a portion of the heart which receives less blood, that undergo necrosis. And necrosis is permanent. In angina, there was no necrosis. It was ischemia. Here it is necrosis. Which necrosis? There are 5 types of necrosis: coagulative, liquefactive, caseous, fibrinoid, fat. Due to less blood supply, it is always coagulative necrosis. So there is coagulative necrosis in the wall of the heart, and this patch is known as infarct. The coagulative necrosis patch is the dead patch. It is known as infarct. So there is infarct in the heart, that is known as MI. You got it? Now there can be three reasons of coronary obstruction. The most common is atherosclerosis in the coronary. Number one. So most common is the atherosclerosis in the coronary. Second, superadded changes in the atherosclerosis, that is thrombosis. Either thrombosis or calcification occurs. And third is spasm of the coronary. Due to the coronary spasm, that is non-atherosclerotic cause, there can be obstruction in the coronary. Now, what are the type of infarcts? It is very important to understand the type of infarcts. There are two type of infarcts. What do you mean by that? For that, you have to understand this diagram. You tell me if there is obstruction here in the coronary, in the big coronary, you can see small coronaries are going in the wall from outer to inner side, So this is the thickness of the wall. If there is obstruction in this coronary, which portion of the wall will show necrosis first? The inner half of the wall or the outer half of the wall? I'm asking to you this question. Imagine this is the wall of the heart, you can see, and this is the coronary. Let me draw the coronary here. This is the bigger coronary. From the bigger coronary, the small coronaries are coming and going in the heart. From outer to inner side, they are going in the wall. If there is an obstruction here, just suppose this is the obstruction. So less blood is coming here. So less blood is going in all of them. There is less blood in all of them. So less blood is going in the wall of the heart. So which portion of the heart will show infarction first? The inner half or out? This is inner half. This is lumen here, or the outer half. Which portion? Common sense. The common sense is that inner portion already receives less blood. As the blood is from outer to inner side, see the arrow. Blood is coming from outer to inner side. So inner portion is already compromised. It is receiving less blood. So whenever there is obstruction, it is the infarct which start from inner side. Infarct will start from here. From inner side, it will start. So this is endothelium of the heart. The layer of the heart, the innermost layer is endocardium. It is endocardium of the heart. And in the myocardium, the infarct is starting near endocardium. Just behind the endocardium, it is starting and going ahead. And one time will come, it will involve the entire wall. So the two type of infarcts are in front of you. So infarct which is occurring only in inner half, or infarct which is involving throughout the full thickness. It will start from inner half and then gradually involve the full thickness. This infarct is known as subendocardial. It is behind the endocardium. That's why subendocardial infarct. And this infarct which involves the throughout full thickness of the wall, it is known as transmural infarct. So the two type of infarcts are subendocardial and transmural. Have you got it? That is the two type of infarct that I want to explain you here. So you can see if I'm cutting the heart from here and looking from above. So this is left ventricular cavity. This is right ventricle. This is left ventricle. See the yellow infarct. Can you see the yellow infarct? It is starting near endocardium. So this is subendocardial. And gradually after starting from here, it is moving out and involving the full thickness. So it is transmural. So the two main type of infarcts are subendocardial and transmural. Subendocardial, only inner half is involved. Transmural, full thickness is involved. Most common it is the transmural, 95%. Only 5% is subendocardial. Give me a thumbs up. Now, I would like to explain you this beautiful diagram from Robbins. You can see this beautiful diagram from Robbins. Let me explain you this diagram. See, I am cutting the left ventricle from here, and I am showing the thickness here. See, this is the left ventricular thickness you can see. This is the left ventricular thickness you can see in the second diagram. In the third diagram also, it is the left ventricular thickness you can see. Please appreciate this coronary. Let me draw this coronary, this coronary, this coronary. Now the coronary is started obstructing. Obstructed coronary. Till now I can't see any infarct here. Now when the coronary is obstructed, infarct is starting from which side? You see, where is the infarct? So this is the infarct. You see, infarct is starting from inner side. So inner half is involved and gradually it will increase and full thickness is involved. In this diagram, full thickness is involved. Can you see? So this is subendocardial and this is transmural. So initially in the first 2 hours it is subendocardial and gradually within 24 hours it will become transmural. I want a thumbs up on this point. So these are the two type of infarcts you should understand. Now coming on the next topic, what is the location of the infarct? What is the location of the various type of infarcts? It depends on which branch of the coronary is obstructed. I have already explained you this diagram. If LED is obstructed, that is left anterior descending, so infarct will be there in the anterior wall. If LCX is obstructed, so infarct will be there in the lateral wall of the left ventricle. And if RC is obstructed, infarct will be there in the posterior wall. So infarct can be in any wall depending on the location. Now, most commonly you tell me out of these three, which is obstructed? So this is the sequence: LAD followed by RCA followed by LCX. I have told you this is the sequence. So LAD follows anterior wall. So anterior wall is the most common wall in which infarct is there. RCA supply posterior wall and LCX supplies lateral wall. So two MCQs come in your exam. According to coronary, this is the sequence of getting obstruction in coronary, and according to wall, this is the corresponding wall these arteries are supplying. So this is the wall of the heart. So most commonly infarct is seen in anterior wall of the left ventricle, followed by posterior wall, followed by lateral. So most common coronary and most common wall, least common coronary and least common wall. Two MCQs are there on this point, and it is the most important MCQ repeated many times in your exam. Have you got it? What I am saying? What is the sequence of coronary? The most common coronary to get obstructed is LAD, followed by RCA, followed by LCX. So this is the sequence in the coronary. Now LAD supplies anterior wall, RCA supplies posterior wall, and LCX supplies lateral wall. So these are the corresponding walls these coronaries are supplying. So this is the sequence of the walls which are which shows the infarction. So question can come: what is the most common coronary to get obstructed? Answer is LAD. Which is the most common wall of the left ventricle which has infarct? Answer is anterior. Which is the least common coronary to get obstructed? Answer is LCX. Which is the least common wall in which infarct is there? Answer is lateral. And second most common coronary and second most common wall involved. Give me a thumbs up again on this point. I tried hard. Give me a thumbs up. Okay. Let me move ahead after the location. A beautiful diagram from Robbins. Again, a beautiful, very beautiful diagram from Robbins. Let me explain you this diagram. Let me explain you this diagram. Can you see on this side? See, this is right ventricle, left ventricle, right ventricle, left ventricle. You can understand now the lumen of the two ventricles, right? See the three coronaries. This is anterior LAD, this is LAD, this is LCX on the lateral side, and this is RCA. Which one is obstructed in the first diagram? You can see in the first diagram LAD is obstructed. It is completely obstructed. In the second diagram, it is LCX is obstructed. In the third diagram, RCA is obstructed. Now see the infarct in which wall it is occurring. When LAD is obstructed, infarct is occurring in anterior wall. Yes, when RCA is obstructed, infarct is occurring in the posterior wall. And when LCX is obstructed, infarct is occurring in the lateral wall. And please appreciate, whenever the obstruction is complete, you can see it is completely obstructed. It is completely obstructed. So please see the infarct is transmural, involving the entire thickness of the wall. It is transmural. So it is transmural infarct. You can see the three type of transmural infarct in the three walls depending on the three coronary. So which coronary obstructed, that corresponding wall will show the infarct. Coming on the other way around, the second type of the diagram, the second half of the diagram. See here also we have three coronaries. Okay, you can see this is LAD. You can see this is RCA, and you can see this one is LCX. Here coronaries are not completely obstructed. They are partially obstructed. Here they are completely obstructed, and here they are partially. So you can see the infarct in the corresponding wall, but infarct is transmural. It is not complete infarct, it is transmural. So when coronaries are partially obstructed, it leads to transmural subendothelial endocardial infarct. And when coronaries are completely infarcted, it leads to transmural infarct on the corresponding wall. So a beautiful diagram from the Robbins. I have explained you transmural and non-transmural, that is subendocardial infarct. Depending on the coronary, please appreciate the coronaries. Here they are completely obstructed. Here they are partially obstructed. Please appreciate that. Give me a thumbs up on this point also. So, okay, we have done this point. So let me move on the morphological features. Let me move on the morphological features of the MI. So the link is expiring. I will take the morphological lecture, features of MI in the next lecture. Now, why morphological features? It is very important. Why you have to study the morphological features of MI? Just suppose there is a person, the person is dead of MI. It is suspected the person is dead. The death of the person, what is the cause of the death? It is MI. Now you don't know whether the cause of the death is MI, yes or no. You want to prove it. So you will do the autopsy. You will do the autopsy of this dead body, post-mortem of this dead body. In the post-mortem, you will take the heart out. You will take the heart out of the body. So this is the heart. In the heart, in the left ventricle, you will search for infarct. Whether infarct is present in the left ventricle, yes or no. If it is present, what is the age of infarct? How old is the infarct? Is infarct 1 year back or 1 day back or 10-year back? What is the age? It matters in medico-legal cases. So that's why you should know the morphological features. You should know the various morphological features. The various morphological features of MI. Okay, I will complete it in this lecture. It will take next 10 minutes. I will finish it right now. Listen, in the morphological features, what I am saying, just suppose there is a person, the death is suspected due to MI. So you are doing the post-mortem and autopsy and you are a doctor from medico-legal team, right? You are a forensic team doctor or a pathologist. So what you will do, you will take the heart out of the body. You will take the heart out of the body. So this is the heart I am taking out of the body. Just a second. So what I will do actually, just let me draw a diagram for you. So this is the heart. I have taken the heart out of the body, right? This is the left side, this is the right side. Most of the infarcts occurs in left ventricle. So I will cut the entire heart in multiple slices like this. 1 centimeter each. 1 centimeter thick slice I will cut. I am having multiple slices with me. In each slice, there are two cavities. One cavity is right ventricle, one cavity is left ventricle. I want to search for the infarct in the wall of the left ventricle. Anterior wall, posterior wall, lateral wall and medial wall. Right? I want to search for the infarct. So I will take each slice one by one and take a magnifying glass and search for the infarct in the wall of the left ventricle. I will search. So sometimes I may found a small yellowish patch anywhere in the wall. So that is infarct. Infarct look yellow in color. But you will see, ma'am, it is very difficult to find infarct in this way. It is very difficult. Sometimes we can miss it. Yes, definitely we can miss it. So what you have to do for this, what is the solution of this problem? You take all the slices. These are your slices. You take all these slices, take a bucket of water, take a big drum bucket, fill it with a dye. The name of the dye is TTC. What is the full form of TTC? Tetraphenyl tetrazolium chloride. TTC. Take all these slices and keep them in TTC for few hours. Keep them. Then take it out. Now, what is the principle behind it? TTC is a dye, tetraphenyl tetrazolium chloride, which will be taken by viable, only viable myocardial cells will take this dye. Since the dye is red in color, so viable cell will become red in color because they pick the dye. But the dead cell, non-viable cell or dead cell of the heart will not take the dye. So it will remain yellow or pale in color. So what is the principle? Why? Why? Because dead cell is the intact cell. Let me draw. Viable cell is the intact cell. And it has enzymes inside it. One of the enzymes is dehydrogenase. One of the enzymes is dehydrogenase, and dehydrogenase form a bond with TTC. So the viable cell will take TTC inside it. The red color dye is the TTC. Viable cell will take inside it and dehydrogenase will form a bond with TTC. So that's why this cell will look red in color. But what about dead cell? Dead cell is bursted. It is already bursted. So all the enzymes or cytoplasm is already lost. There is no dehydrogenase inside it. So it will not take TTC inside it. So it will not look red. It will look yellow. So that is the principle. Now see each slide. Can you see this slice? Can you see the slice? In this slice, this is the left ventricle. This is the right ventricle. Look out the left ventricle. The walls of the left ventricle. Here you can find a yellow patch, and rest all is red, rest all. So this is all viable, only this portion is dead. So you can easily pick the dead portion. Here also you can see this is the dead portion. Okay, this is the dead portion. This is non-viable area because it is looking pale. Have you got it? The rest of the myocardium is red in color. So that is on TTC you can identify. So that is the relevance of TTC. Have you got it? What is TTC? What is TTC? It is tetraphenyl tetrazolium chloride. Triphenyl tetrazolium chloride, TTC, right? What is the principle? The non-infarcted, that is viable myocardium have dehydrogenase preserved inside it. So it will take TTC and give brick red color, right? But the infarcted area, that is dead area is bursted. There is no dehydrogenase. It will not take TTC. So it will remain pale or yellow only. So that is the principle. Again, give me a thumbs up. It was a big concept I have given to you. Right. Now, coming on the microscopy. You got the infarcted area. You cut this area and make a slide. Make a slide of it. You cut the infarcted area, make a slide of it. You should ask me, ma'am, why we are making the slide? We have already found a patch grossly. So MI is present. So my question was whether in the dead body MI is present or not present. So in this dead body, you concluded, ma'am, that MI is present. We can see it grossly. Grossly, with the help of TTC, we found MI. Ma'am, my second question, what is the age of this MI? Whether this yellow color patch you can see in this diagram, this yellow color patch you can see, it is 10-day old, 1-day old, or 10-year-old. What is the age? What is the age? It is important to know the age. For this, you have to make a slide. You have to make a slide. Now, I will show you 10 diagrams. I will show you 10 diagrams depending on 10 time zones. If the MI is half hour old, diagram will be different. Half hour to 4 hour old, diagram will be different. 4 to 12 hour, 12 to 24 hour. 24 hour means 1 day. 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day, 2 to 8 week, and more than 2 months. So there are various types of time zones you can see here depending on with different diagrams I am having. So I will show you all the diagrams one by one. Okay, so this is the beautiful table from the Robbins. It is a complicated table. I have simplified this table in this way. Okay, 0 to half hour, I will show you 10 diagrams. So it is normal. You cannot pick up infarct in 0 to half hour. Heart will look absolutely normal. After 30 minutes, half to 4 hours, there is waviness. So waviness is the first change. What do you mean by waviness? See the lower half of the diagram. Can you see cardiac muscles? Yes. You can see these long fibers are cardiac myocytes. There are 3 type of muscles, na? Skeletal muscle, cardiac muscle, and smooth muscle. Cardiac muscle, these are the nucleus. In the cardiac muscle, these are the striations. Can you appreciate these light and dark striations are there in the cardiac muscle? It is normal. Instead of being straight, it become wavy. It become wavy. So half to 4 hour waviness. Can you appreciate the waviness? Appreciate the waviness. So it is normal. The only thing it is wavy. It is wavy. 4 to 12 hour, it will show coagulative necrosis. It will show coagulative necrosis. Now see the upper half of the diagram. So can you see the fibers converted pink in color? The nucleus is disappeared. Can you see the dark pink color fibers? All the cardiac fibers are dark pink. There is no striation, no nucleus. So they undergo necrosis. So it is coagulative necrosis which is seen 4 to 12 hours. After 12 to 24 hours, along with coagulative necrosis, you will find few neutrophils. You will find few. So please appreciate few neutrophils here. In this diagram only, appreciate few neutrophils. These are the multilobated neutrophils, right? After 1 to 3 days, along with coagulative necrosis, you will find abundant neutrophils. That is brisk neutrophil. See this diagram. So again in this diagram, can you see the coagulative necrosis in the fibers? Yes, you can appreciate the coagulative necrosis is there, the pink color fibers. But along with it, appreciate the count neutrophils and compare it with this. So here few neutrophils were there, and here please appreciate the neutrophils. Abundant or brisk neutrophils is there. So brisk neutrophils is there. So please revise till now. What was it? Normal, waviness, only coagulative necrosis. Coagulative necrosis with few neutrophils. Coagulative necrosis with brisk neutrophils. Now, at 3 to 7 days, neutrophils start decreasing and macrophages start increasing. Another cell is coming, macrophage. Can you see in this diagram? Let me mark macrophages for you people. I will mark it for you. So see this cell, this cell, this one, this one, this one, this one, and this one. Count it. So hardly I can find few macrophages. Rest of them are neutrophil. Neutrophils are multilobated. Macrophages are single lobated. So you can see many macrophages inside it. You can see many macrophages inside it. Give me a thumbs up. So neutrophils are starting decreasing and macrophages are increasing. What are macrophages? Macrophages are phagocyte. They will eat the dead muscle. They will start eating. Now please appreciate the dead muscle is disappearing. These cells will start eating. These cells will start eating the dead muscle. So if dead muscle, this pink color muscle is disappeared, what will remain? In the background, there will be collagen. In the background, there will be collagen with blood vessel. It is known as granulation tissue. See the lower half of this diagram, it is having dead muscle. So dead muscle is disappearing because macrophage is eating it. Macrophage is doing phagocytosis. See the upper half. The dead muscle is disappeared and background have collagen and blood vessel. It is known as granulation tissue. So granulation tissue start appearing at 7 to 10 days because macrophage will eat the dead muscle. Now there is no more coagulative necrosis. It is eaten up by the macrophages. Now there is granulation tissue appears. Granulation tissue will become maximum and then it will result in scar. It will result in scar. In the end, nothing will remain, only scar. Only scar. Give me a thumbs up. I have shown you 10 diagrams. Who will help me in filling the table? Divide 10 diagrams, 10 time zones. 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. 24 hour means 1 day. 1 to 3 day, 3 to 7 day, 7 to 14 day. 14 day means 2 week. More than 2 week, 7 to 10 day bhi tha. 7 to 10, 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. 7 to 10 day and 10 to 14 day. 14 day means 2 week and 2 months. So divide them into 10 zones. These are the 10 zones in front of you. 0 to half hour, it will be normal. Half to 4 hour, it will be waviness. Waviness. 4 to 12 hour, it will be only coagulative necrosis. Here, 12 to 24, along with coagulative necrosis, few neutrophils are there. 1 to 3 day, along with coagulative necrosis, brisk neutrophils. Imagine the diagram. Brisk neutrophils are there. At 3 to 7 day, neutrophils start decreasing and macrophages start increasing. Macrophage will eat the dead muscle and lead to the formation of granulation tissue. So 7 to 10 day, granulation tissue will appear. 10 to 14 day, granulation tissue will become maximum. And in the end, collagen and scar will form. Everyone give me a thumbs up. I really tried hard in helping you in simplifying this concept. So please learn it. Please learn it. That is the diagrams from the Robbins showing the various time zones. Many MCQs come from this point. Many. So can you revise the entire table? So I'm not doing the entire revision. I would like to show you few MCQs based on this table, this concept. So you will have an overview that why this topic is very important. So can you do the first question? What is the answer here? Reversible injury in myocardium occurs till what time? Till 2 minutes, till half hour, till 2 hour or 5 hour? Yeah, the correct answer here is half hour. Till 30 minutes it is reversible because in the table you see no change till half hour. So the injury is reversible. So the correct answer here is B, right? You all are right. So coming to the next question, that is a good question. Please read it carefully and please don't rush. During the autopsy or postmortem of a patient, there is a patient who is already dead. That's why you are doing the autopsy and postmortem. The patient is suspected MI. The death is due to suspected MI. So you have taken the heart out of the body and stained it with a dye known as TTC. You already know what is TTC. Tetraphenyl tetrazolium tetrachloride. TTC. What is the color of viable myocardium? Viable. I'm not asking dead. Viable myocardium. So is the color will be blue, white, red or dark brown? So viable myocardium have dehydrogenase enzyme inside it that will take the dye TTC. Since TTC is red in color, it will become red. So correct answer here is red. Correct answer here is red. Instead of viable, if I ask non-viable, what is their answer? Answer will be yellow. Yellow is not given in the option. Answer will be yellow. Have you got it? So here answer is red. So I have already told you this portion you can see this is dead. That's why this is yellow. The remaining portion is viable. That's why it is red. So image based question can also come on this beautiful concept, TTC dye. So you should be prepared for that. Coming on the next question, it is really difficult level question from AIMS. Few years back we have AIMS now instead of INICT. So this is a question from AIMS. Okay. A 45-year-old male have severe chest pain and he was diagnosed as acute MI in the hospital. He was brought to the hospital immediately. In the hospital, ECG was done and he was diagnosed he is having MI. So diagnosis is already given to you. 4 days after chest pain, he is dead. So after MI, he was having MI when he was having chest pain. After chest pain, 4 days later, please mind the word 4 days. 4 days later, he is dead. He is dead. So autopsy will show coagulative necrosis along with which of the following feature? At day 4, what is your finding? Along coagulative necrosis तो होगा ही होगा और क्या होगा साथ में? Will you find fibroblast? Will you find granulation tissue? Will you find neutrophil with coagulative necrosis or will you find with granulomatous tissue? At day 4. You want to see the table? At day 4. Now you tell me what is your answer? At day 4. At day 4. At day 4, you find coagulative necrosis. Only coagulative necrosis. But only coagulative necrosis is not the option, right? But you won't find collagen. Collagen kab aa raha hai? Collagen is coming later on. This is collagen. It is not at day 4. It is not. I'm sorry. This is 4 hour. I'm sorry. The question is about day 4. Day 4 is coming here. This is day 4. 3 to 7 is day. I was confused between hour and day. I'm sorry. This is day 4. In day 4, you will find neutrophils with macrophages. But none of the option is showing neutrophil and macrophages. So best option to go here is C. It is not collagen, it is not granulation tissue. Granulation tissue is coming later on. It is 7 to 10 day. It is not day 4, right? So best to go here is C. Have you got it? One more question based on this concept. What is the earliest histological feature in MI? सबसे पहले क्या होता है? Earliest. Is it macrophage who is coming earliest? Is it neutrophil who is coming earliest? Is it waviness or is it coagulative necrosis? Yes, it is a very easy question. So earliest among these is waviest. Waviness. Yes, C is the answer. Waviness. C is the answer. Instead of earliest, if I ask latest, what is the latest among these four? सबसे आखिरी में क्या होगा? So can you make a sequence? So सबसे पहले waviness, after that coagulative necrosis, after that neutrophil, after that macrophage, then granulation tissue. So you know the complete sequence. It is waviness, then coagulative necrosis, then few neutrophils, then brisk neutrophils, then macrophage, then granulation tissue, then collagen, then scar. You should know the complete sequence. Many MCQs can be framed from this. Have you got it? So this is the next question. Very beautiful question. A myocardial infarct showing early granulation tissue, just the start of granulation tissue. Granulation tissue occurs at what point? So you can see the table where granulation tissue is occurring. First time granulation tissue occurring 7 to 10 day. Early granulation tissue. This is early. Macrophage is eating the dead muscle, and instead of dead muscle, the background have blood vessel and collagen. That is known as granulation tissue. So 7 to 10 then is my answer. It is which option is best fitting here? The best fitting option is within 1 week. 7 day means 1 week. So I will go with C. I will go with C. Have you got it? Have you got it? Yes or no? Yes or no? So this is how you have to approach the questions. Coming on the next question. Again, a beautiful question and a difficult one, I guess. Okay. So in MI, microscopic pictures show coagulative necrosis with neutrophils. So you are getting coagulative necrosis with neutrophils, but it is not mentioned neutrophils are few or brisk. So what is your answer? What is the age of the MI? What is the age of the MI? Yes? What is the age of the MI? So few कब आते हैं और brisk कब आते हैं? Few neutrophils come at 12 to 24 and brisk come 1 to 3 days. So if you consider few, answer will be this. And if you consider brisk, answer is this. So answer is few or brisk. What you will consider? Both answers are correct. So if question contains few, my answer will become B. If question contains brisk, my answer will become C. But nothing is mentioned in the question, so I will go with brisk. I will go with brisk. That is the most, exaggerated finding. So usually examiner should mention it, not to confuse you. But if it is a PGI exam, answer will be both. So go with C. If nothing is mentioned, otherwise it should mention specifically. This is the last question in front of you. The cells seen after 72 hours in the infarcted area. 72 hours के बाद कौन से cells होते हैं? What do you mean by 72 hours? 72 hours means 3 days. After 72 hours. I'm asking the cells after 72 hours means 3 days. 3 days. So 3 days के बाद 3 days पे कौन से cell आ रहा है? Macrophages. After 72 hours. It is the macrophages which are coming here. So answer will be C. Have you got it? Cells seen at 48 hours. 48 hours means 2 days. 2 days. So 2 days, it is the neutrophil. So if the cell asks at 48 hours, answer will be neutrophil. If the cells asked at 3 days, it will be macrophages. So in short, you have to learn this table. There is no escape. It is a master table. And you have seen how many questions examiner frame from this beautiful table. This is the table of morphological features of MI to know the age of the MI or how old MI is. Everyone give me a thumbs up. I tried hard. And the link is expiring, so I have to end here, stop here. But before stopping, there are few announcements for you. Let me do these announcements. Thank you very much for being with me. On Unacademy, we have two types of paid subscription, right? This is a free YouTube class, but on the platform, we have two types of paid subscription in which we cover all 19 subjects in a structured way under the batches. In Plus subscription, you will get access to live and recorded lectures. Under Iconic, along with Unacademy subscription, we will provide you Preparator also. So better to purchase Iconic if you want to purchase one, because here you are getting additional advantage of Preparator. Price difference is a little bit. Unacademy have already, the hard copy of the notes is already there. So the hard copies is available. You can order your copy if you want this copy. Anyone who is taking Plus subscription for equal or more than 1 year, the hard copy of the notes is free currently. So please grab this opportunity, take the advantage of this opportunity. You can see here, we have a batch of one of the top educators throughout the India. Once you take the subscription, you will be eligible for all these batches. You can check the prices of various subscription under Plus, under Iconic, whatever subscription you want according to your wish, according to your need. You can take this subscription. You can notice longer the subscription, cheaper it is, right? So my advice to you, go with a longer subscription, 4-year, 3-year, and whatever subscription you are planning to take, please apply code SACHDEV10 before payment so that you will get maximum discount. You will get maximum discount in the subscription, right? So the code is SACHDEV SACHDEV10. It will be applicable on Plus as well as Iconic. Thank you very much. See you back in the next class with another important and topic for university exams as well as competitive exams from the pathology. Thank you very much. Study hard. Bye-bye and wish you all the best.